Now in this video we're going to see myelodysplastic syndromes. What are myelodysplastic syndromes? Myelodysplastic syndromes are a group of diverse bone marrow disorders characterized by ineffective erythropoiesis. This results in cytopenias and increased risk of transformation into acute myeloblastic leukemias or AML. Now, what are the clinical features of myelodysplastic syndromes? Depending upon the patient's disease, some patient may be asymptomatic, they may be fatigue and shortness of breath because of the low hemoglobin. There may be bruising or bleeding tendency because of thrombocytopenia. There may be increased propensity for infections and recurrent infections because of neutropenia. Some of the patients may have bone pains, they may have weight loss. When you examine, you'll find they may be pale. Some of them may show bruising, and in some patients there may be splenomegaly as well. And then what is the international prognostic scoring system on the basis of which we stratify the patient with myelodysplastic syndrome? So we use multiple variables and scoring systems, score from 0 to 2 for different variables. For example, if we take the percentage of blast in the bone marrow, if they are less than 5%, this is 0 score. If they are between 5 to 10%, it is 0.5. If they are between 11 to 20, this is 1.5. And if they are between 21 to 30, the score is given as 2. Similarly, karyotyping, if they have a normal karyotype, they have deletion 5q or deletion 20, they are given a score of 0, while complex problem with 3 or more abnormalities or abnormal chromosome number 7, this is given a score of 1, and rest of the abnormalities are given a score of 0.5. Cytopenias, if there is no cytopenia or 1, this is given a score of 0. If there are 2 or 3 cytopenias, this is given a score of 0.5. Now, on the basis of this, we can have risk groups. Low risk group have 0 score, intermediate 1 have 0.5 to 1 score, intermediate 2 have 1.5 to 2 score, and the high risk patient have 2.5 to 3.5 score, on the basis of which we can design treatment of these patients. Now, if the patient comes with unexplained progressive cytopenia with macrocytic anemia, check for the exposure to chemotherapy, radiotherapy, and toxin which may be causing cytopenias. And if you are suspecting that this is MDS, go for a peripheral smear. Patient may have progressive symptomatic cytopenias, they may be bicytopenia or pancytopenia, they may be isolated cytopenias like hemoglobin is low. If it is less than 10.0 gram per deciliter, exclude GI bleed, nutritional causes, hemolysis. If the platelet count is less than 100,000 per microliter, exclude ITP, hypersplenism, and clumping of the platelets. If the neutrophil count is less than 1500 per microliter, exclude T cell large granular lymphocytosis, familiar or cyclic neutropenia, hypersplenism, autoimmune disorders, exposure to medication and toxins. The NCCN recommends a comprehensive testing for patients who are suspecting MDS. They include history and physical examination, complete blood count with retics, peripheral blood smear, bone marrow for iron stain and cytogenetics, erythropoietin, red cell folate, B12, ferritin, iron, TIBC, and documentation of transfusion history. The patient may be referred for specialist assessment. So when we are planning treatment of these patients, we treat according to the risk groups. If the patient is asymptomatic low risk group, we just observe until it progresses or patient becomes symptomatic. If the patient is high risk and the patient is candidate for transplant, allogenic transplant may be offered. HMA may be used to bridge the gap between the diagnosis of the disease and transplant. Patients who are not suitable for transplant, HMA may be used until disease progression or intolerance. Patients who are low risk, see if they got anemia with deletion Q5, they may be offered lenalidomide. If they've got anemia with erythropoietin which is less than 500 units per liter, they may be offered erythropoietin stimulating agents. For other anemias, we may use lenalidomide or hypomethylating agents like azacitidine or dactabine, or they may be offered immunosuppressive therapy or supportive care alone. For other types of cytopenias, they may be given growth factors or hypomethylating agents or immunosuppressive therapy or even just supportive care. So this is the plan of treatment for patients who got myelodysplastic syndromes.